Thank you. Thanks very much. Okay, we're moving on to item 3, which is declarations of interest. To receive any declarations of interest, having looked at the agenda, please, ladies and gentlemen. None whatsoever. Okay, thank you very much for that. So I'm now going to move on to item 4, which health inequalities funding. It's the South Staffordshire Partnership Community Wellbeing Plan. And that's the presentation by the Corporate Director of Place and Communities, Assistant Directors, Community Services and Partnerships.
Thank you. Thank you, Chair. Oh,
I'm not sure if I'm right. Yeah, can you think about playing with it?
Can you? There you go. I think that's working now. Okay, thank you. Thank you, Councillor Chapman. What Mark and I will do tonight is a little bit of a double act for you, and this is relating to some community funding. We just want to set this out in terms of the context, in terms of the proposal that we have in front of you this evening, and explain a little bit about the governance of that, a little bit about the legacy, where this has come from, and a little bit about the principle and the formula that we've come up with in terms of this funding. So the slide that you've got in front of you really starts to show the where we're coming from with this. You'll all be very much aware, I'm sure, in terms of the Localities Plus model. What we've been doing over the past 6 months has been really looking in terms of creating a partnership plan. And that partnership plan focuses around 2 key strands. One's economic wellbeing and one's community wellbeing. And it's the box on the right-hand side, really, where we're focusing this evening. The UK Shared Prosperity Fund really focuses on the economic wellbeing element of it, but this funding will help, I think, plug some of the gaps as well in the community wellbeing proposals. So as a part of the partnership, we've had a partnership running now for a couple of years, and we've in the last probably 18 months we've been meeting back together in the room as opposed to virtual, and from that we've started to have the conversations about what we're actually going to do collectively as part of the partnership. How do we add value? And through this has come partnership plan. The community wellbeing is in terms of brings with it 3 different strands: better health, ageing well, and community is the best medicine. And within there's a whole host of various different interventions that we've been looking at finding to do. And ultimately, the various different agencies and partners involved in delivering these detailed actions and detailed interventions, but there remains gaps within the provision. So at the same time, Mark and Dave Hayward, the Chief Exec, have been having conversations at a county level in relation to health. And that is where the conversations about the health partnership and about health funding have come from. So as I said, I'm going to do a bit of a double act. So I'm going to so that's a bit of the context. So I'm going to pass you over to Mark now, who's going to talk a little bit about the funding and where it's come from and what we'll be able to use it for. Mark, you have to get your hand on that. Thanks.
Thank you, Annette. Good evening, members. So the next part of the presentation, I'm going to take you through some funding which has been allocated to us from the Health Inequalities Directors Group. Over recent years, quite successfully, a similar group has been set up across Staffordshire to focus on the economy. And I think it's a real positive move that a similar group has now been set up to look at health and wellbeing as well. So working very closely with colleagues at the County Council and other districts and boroughs across Staffordshire. So earlier this year, a group has been set up titled the Health Inequalities Directors Group. That's chaired by Dave Hayward and co-chaired by Tim Clegg, who's the Chief Executive of Cannock, Chase and Stafford Borough District Council. Again, Richard Harling, the Director of Public Health, is heavily involved in that group as well. So initially that group has been brought together to look at some of the challenges and hotspot issues across Staffordshire as a whole, and how we can work together with colleagues in public health to tackle some of those challenges in our districts. Ultimately, if we get that right and focus on the preventative agenda, it should have a knock-on effect in terms of secondary care and people entering our healthcare system. So potentially we've not focused on some of the preventative aspects. I think we've done a lot of good work on that previously. Some of that has fell down, and COVID is obviously taking a big focus away from everyone, but I think it's a positive move that we've got partners and districts and boroughs back around the table to look at the role we play. Again, we significantly play a part in lots of our residents' lives across the districts and boroughs within Staffordshire, and I think it's important that we have a voice and that we can make some positive change within our patches. Next slide, please, Mark. Okay, so quite fortunately, and again quite timely as well, linked to the Health Inequalities Directors Group, each of the districts and boroughs across the county have been allocated a pot of funding, which is leftover funding from COVID or comp grant for people who've been involved over COVID. Some of that money has been directly spent by public health colleagues. Other parts of it has been delegated down to districts and boroughs in terms of their response to COVID. However, there's a chunk of that money that's not been spent, and what the Director of Public Health is prepared to do is to allocate a proportion of that to districts and boroughs to spend. As you'll see there on the three key areas it needs to be spent against, a lot of it has a COVID focus. However, it broadly can be spent on health prevention measures, mitigating inequalities, as well as some of the future preventative measures regarding outbreaks. So it's quite a broad funding pot, but each of the districts and boroughs will need to bid into that. So there's an allocation of funding which we've all been given, but we still need to go through a process to draw that down at a district level. Next slide, please, Mark. So there's three direct funding pots which are available to all districts and boroughs across Staffordshire. The first one is a Health and Care Hardship Fund. This one has been divided evenly across every district and borough. So there's a pot of 25k available for each of the districts and boroughs to bid into. This one is regarding health and care hardship funding. So this pot of funding is really regarding some of those wicked issues, or where issues fall between a gap and no one can decide if it's their job or really wants to take it on. But actually there's issues that need dealing with and tackling. So this is a smaller pot of money, which if there's something does fall between a gap between partners, if we can get that resolved and move things forward, this pot is there for those type of problems, such as deep cleaning properties or flea infestations, or again whether there's an external contractor that needs to be brought in to support a partner agency if they haven't got the direct resources to tackle those issues. Again, what I will say with all three of these pots is it's very much at the districts and boroughs' discretion how they utilise that funding. So some districts and boroughs will put it directly into their coffers. What we're looking to do with the funding in South Staffs is make it available to a range of partners. So again, on the mantra of who's best placed to deliver. So if successful, we'll be drawing that funding down to a district level. But what we want to then do is open it up for wider bids. So it will be open for our teams internally to bid into, but in addition to that, voluntary sector will also be able to bid into it, as well as any private sector businesses who feel they can tackle any of those agendas. So the first pot is a pot that will be available. Again, at this point in time, that could be brought down to a local level and partners can bid into it. But at the moment, County Public Health colleagues are going to hold that part of funding for all the districts and boroughs, and we've got an equal allocation, but we might make a case to bring that down and utilise it as a local levels, and hopefully we can ensure that it gets to the right places quicker if we take that approach. Next slide, please, Mark. The second element is where public health colleagues have used intelligence and data. So this is where there isn't an equal split across districts and borough in terms of their allocation. And again, using the intelligence and data, Public Health Insight team have looked at areas across Staffordshire where the biggest areas of health inequalities. For ourselves and Lichfield, we don't have any areas or wards across our district which hit that higher outcome or red level areas. However, we do have a number of amber areas across South Staffordshire where we will be allocating some of the housing and health funding, which I'll come on to slightly later. So we've got not an insignificant pot of money, 151k. Again, as I picked up earlier, what potentially some of the districts and boroughs will do is draw that down and utilise it against their own services. I think we've all had the conversation internally that probably isn't the right thing to do, and I think we can be a little bit more progressive and try and ensure that we're tackling some of those issues which Annette had alluded to via the partnership plan. So again, members will be aware that some of the challenges have been issues for a long time within South Staff. Those have been identified via the data, but also the partners as well who have flagged those are issues for ourselves. So what we'll be looking to do is use the 150k to tackle some of those issues. But again, we'll be looking to draw it down. Our teams can bid into it at a district level, but it will also be available for voluntary sector partners or any local businesses as well who can tackle those issues. Again, the mantra, who's best placed to deliver, but most importantly, what we want to do is ensuring we're delivering in helping reduce some of those wider determinants and setting ourselves some challenging targets and outcomes to demonstrate that we can make a difference. This pot of funding is non-recurring, so once it's gone, and we've got till 2024 or September 2024 to spend that funding. However, there is the potential that there might be wider NHS funding that's cascaded down to districts and boroughs via the integrated care system, but I think we'll be better placed if we can demonstrate we can deliver. Again, it's a lot harder to demonstrate that preventative measures are achieving outcomes. You don't see that overnight. It takes a longer time to show that, but what we're mindful of, that if we want to get reoccurring funding, that we've got to demonstrate at district level that we can deliver and hit some of those outcomes. So we'll be ensuring that that's built into our application process. Next slide, please, Mark. The final part of funding is regarding housing and health, and this is a pot of funding of 86k, which will be delegated down to ourselves at district level. As with the previous pot, we've got to bid into that process. Those bids need to be in by this Friday. Again, what we'll be looking to do is try and deliver those aspects around the partnership plan where gaps have been identified, where there isn't any service provision in those areas at the moment. So any commissioning opportunities are delivering around where there's gaps, not duplicating what's already there. Sorry, Councillor Barrow. Yes, so within the previous pot, Councillor Barrow, that could be around programmes we've got already established, gentle exercise referral programmes, walk-in to strengthen some of those programmes. It could be environmental health initiatives where we've potentially not got the capacity within team to deliver on it, but if we set up a separate project, for instance, regarding private sector landlords, big focus around damp and mould at the moment. Obviously, we've got good relationships with social sector landlords such as Housing Plus, but there's no formal register for private landlords to register. So we could have people renting out properties across the patch, but they're not regulated in the same way as housing associations would be. You've got some of the work around wider determinants of health, transport related initiatives, any preventative measures that feed into health would be eligible, Councillor Barrow, to bidding. Yes, yeah, that's a big focus, and that's one of the priority areas which has been picked up as part of the partnership work. And we had a partnership meeting on Monday, which Annette chaired, and again we obviously let partners know that funding would be there, and MPFT colleagues who deliver in that area. Councillor Barrow again would be able to bid into that part. Again, a similar vein with the housing pot, what we want to do is, if we're successful, delegate that funding down so other partners could bid into it. Again, other parts of the county have got a bigger pot of funding. Again, as we've not got any wards which are in that higher red category, we've got less or a smaller slice of the pie. Where we have got areas that fall into the amber level is locality 3, so Great Worley, Chesinghay, Essington, and Huntington and Haverton in locality 1, where we've got amber areas. So we have got a number of amber areas, but we've got no red areas of high priority need within South Staffordshire. So where the previous part of 151k, there might be other parts of the district where we can utilise that money for general health preventative measures. I think this part of funding will need to be utilised in those areas which have been identified of where there's housing hotspot areas. So that will be targeted within those areas across South Staffordshire. Again, some of the projects which we could use that funding on, again, we've got different needs from some of the districts and boroughs. So rough sleeping and homelessness isn't as prevalent within South Staff, but some of the areas within South Staffordshire may want to use that money there. We could be using it to bolster the warmer homes pot to carry out more work across South Staffs. Again, we could be utilising it to develop more work internally regarding health in all policies and how all parts of the council link into health. Some of the preventative measures in the home, we could be looking to do more work there in terms of falls prevention, which again is one of the major issues that creates people entering the secondary care system. So again, if we can do more to support partners at a local level, hopefully we can reduce some of those challenges across the district. Next slide, please. I'll pass back to Annette shortly to take you through a number of the other funding streams we've available. So wrapping up, we've got a pot of 236k, which again, from a county-wide perspective, it's not a massive amount of money for ourselves at a district level. I think we've proven before with smaller pots of funding we can do a lot of good work out there in our communities. So again, we'll be bringing it back to the committee if we're lucky enough to draw that funding down, and then we'll obviously keep members in the loop in terms of how we will go about promoting that out to our communities. Again, it will be open to our teams, but again, local community groups, small businesses who can deliver on some of those agendas will be opening up for people to bid into those funding pots. Sorry, Councillor Perry.
Wait for your finger on the button.
Slide, if I may, please. The last slide you mentioned about housing and different private landlords, etc. And on this, I take it this includes Housing Plus on this scenario, which is our biggest house provider in South Staffordshire. Because that's where, if I'm being honest, I get most of my calls for about this kind of thing we're talking about. Locality 3, I get an awful lot of people phone me about Housing Plus and the state that some are there. But I'm just wondering, there's an awful lot of private landlords out there that might need to tap into this, because Housing Plus should be doing this anyway, in my opinion, looking after their residents, which sometimes, unfortunately, I can say they don't. If I may. So I just wondered about the register. Are you going to collate a register of other housing providers within Staffordshire, South Staffordshire?
It's one of the options, Councillor Perry. So if the environmental health team put a bid forward on that basis, it's one of the things we can look at. Again, it will be a competitive process, so it's putting a good case forward to do that. And again, as you rightly pointed out, Councillor Perry, we've generally got good relationships with Housing Plus, and I guess in fairness to Housing Plus, over the last 12 to 24 months, where we had the environmental health team worked really closely with them, and members, you're sometimes the first port of call for residents if they're not happy, and the number of properties on that list and the time it's taken to deal with those issues has shrunk significantly. And Jenny and the team have done a lot of work with HPG to do that. But I guess we have to be fair that they're generally, if we make contact, they seem to be resolving those issues a lot quicker. Again, I guess for housing associations, and we haven't got a housing stock with the focus on damp and mold, that has driven a lot of housing associations to focus there. So potentially some of the other areas of the business may have suffered at the detriment of focusing on damp and mold, but there does seem to be a real drive to try and get that right at the moment for Housing Plus. I think where it does go under the radar is those private landlords, Councillor Perry. So if we could put a scheme in place, it relies on them wanting to come forward and go on that scheme, but it's something that we'll look to try and pursue.
To you, Annette.
Sorry, I think you had another question.
Another question? Councillor Nelson.
Sorry, you've got strengthening existing health and wellbeing programs, and you said it relates to outdoor play equipment. Can that relate to the stuff that adults use, like outdoor gyms and things like that? So you could actually put in bid for that from that supplement.
Yeah, definitely. Again, if we get more people physically active, that's one of the things we're trying to do. So if there's a local parish council or community association that are looking at outdoor gyms, again, that would be one of the areas that people could bid for, Councillor Nelson.
Thank you. Councillor Ashley, please.
One of my concerns is I wonder what the relationship is between cost of living and health, because I am under the impression many people who are short of money have problems with food. It's not mentioned at all in any of your schemes, but in my patch I do know that we have people who use food banks. In fact, when we have to go to Cannock, I've taken the guy to get it. Are we able, I don't know if we've got any food banks within our district, but I just wonder if, bearing in mind these funds here, if they could either set up, support or help the establishment of food banks within our district, particularly in larger villages, because I do think that is an important aspect when it comes to health, both mentally and physically. Now, what is the position in that direction? Are we able to do anything?
Thank you for that question, Councillor Ashley. Again, it's one of the areas we've discussed as part of the partnership group in terms of cost of living and how we can support. Again, I'm aware of one food bank in the district in Wombourne, which the Kingsway Church run. I know residents access others just over the board, and particularly Purton residents, I believe they access one in Wolverhampton. And again, there'd be nothing to stop a food bank if there was a need and demand in South Staffs, if they wanted to extend to bid into this funding to operate and run those resources from South Staffs.
Councillor Evans.
Thank you. Thanks, Madam Chair. Yes, just briefly, I can clarify. The Kingsway Food Bank operates from Wombourne, and over the last few years, I believe about the time of the pandemic, either just before or just after, the years just fly by, that food bank has expanded into Purton, and there's a satellite that's now fully operational. So Purton's moved away from the Well, which is based in the centre of Wolverhampton, to Kingsway Food Bank.
Yes, thank you very much, Councillor Evans. I would further add that St Nicholas's Church, I'm on the committee there. We do work with the food bank in Wolverhampton, and it's very active. It's interesting to know about the Purton one. That's very helpful to members, I'm sure. Right, is it Councillor Harrison? Was it next to Councillor Barrow?
Thank you. Very interesting. I'm on the board of governors at St Nick's School, and they actually have a food bank within the school. and they have 17 families that use it every week. And I think that's so much easier for families to come in to the school and get some food, as opposed to going into another organisation, because, you know, people are reluctant to ask for food. They are ashamed. But I think if they're in the school, it's so much easier to go into reception and say, is there anything that we can have? And I know in Cotswold, we do support this food bank, because I just think smaller ones as opposed to a bigger one is quite good ideas, really, because, as I say, people are more inclined to use them.
Councillor Harrison.
So much. So picking up the very, very important point that was made about food banks, which I do thank my colleague for raising, which headed me off in the past to some extent, but it does link into my real question, which is, okay, so we've got food banks that provide to Kinder and our neck of the woods, some of which, as Mark has alluded to, come from across the border. So my wider question is, you keep mentioning how outside organisations, voluntary sector, etc., can bid in for these funds. My question really is, how are we going to make sure that they know they're available for them to bid in for, especially if they're outside or just across the border somewhere. So it's really how, and I'm very happy to help with that. I'm sure other councillors are, but we really need some sort of easy package that we can say, here, can you fit into any of these criteria? Are you interested?
Yeah, no, that's a very good point, Councillor Harrison, and that will come on to the governance of it shortly. But what we're looking to try and do with this process is mirror what Grant Mitchell and Annette have done with the UK Shared Prosperity Fund. But again, we'll be looking to cascade out via partners, and hopefully yourselves as members as well. You might have contacts and groups and networks that we don't, but again, we're still in the bidding process. So if we firstly, we've got to get the money, and if we've got the money down, then what we'll be looking to do is promote that out to communities to bid into. As I said earlier on, I don't think it will be the same across the whole of Staffordshire. I think some of the districts and boroughs will take it and then use it internally. We're trying to go a step further and not just fill our own coffers. We're trying to put it back out there for other people to bid into as well.
Great, thanks, Mark. Councillor Sutton.
Thank you. Very interesting discussion, and I agree with Councillor Harrison in relation to ensuring that those people who are providing some of these services have an accessible route into this funding or applying for this funding. It also led me to think about the way you answered a question earlier on about knowing of one food bank. Clearly there are more food banks, smaller food banks in the area, and perhaps I'm not wishing to give you any more work, Mark, but a scoping exercise. I know of 2 food banks that run in Coven and Brood. We've obviously got ones that work in Purton and Wolverhampton and Kinber. So it might be worth just a scoping exercise and getting to those food banks a docket or something where they can apply for funding from this particular funds.
Thank you, councillors. Yeah, good point.
Okay. So to you on it.
Thank you. Yeah, and just to reiterate what Mark said, I think one of the key things, you know, the focus has been on in terms of so the tangible, the exercise, the leisure services, etc. But one of the conversations we've been having quite a lot during the conversation with the partners, particularly Better Health Staffordshire, it's been all about ensuring that there's that families and individuals obviously do have food, and I think that's going to be the sort of one of the pushes really from that partnership into the new year. There's been lots of conversations there, and partly some members will be aware of the that they're giving away the pots. I've forgotten the called. What are they called? Slow cookers. Sorry, slow cookers. Recently this autumn in 2 locations in the district and broader. Obviously, that's a county initiative. So there's elements of that funding that's been identified, but also there's things in terms of other opportunities to ensure that we can get out to people. So building on that, really, in terms of the broader health and wellbeing funding streams, this is obviously a key part of it, but it is one part of the broader funding streams. So we've got that top one there, which is the health inequalities funding, which Mark's talked about, which we will be putting bids in if we're comfortable, obviously, if this group is comfortable. There's also got the South Staffordshire Council Community Wellbeing Funding. Now, some of that, there's £20,000 there. Some of that is left over in legacy from some COVID funding. So there is opportunities there for communities to bid into. The third one down there is West Midlands Community Fund, West Midlands Interchange Community Fund. Now that's slightly different in that and it's a 65,000 on there, and that's the first tranche of that funding. There's 100,000 in total. The first part of that was drawn down on commencement of the development, but it has an element of index linking. So that £50,000 is turned into 65,000, and there'll be a further tranche later on down the development proposal when another trigger is met. The West Midlands Interchange Community Fund is secured through the Section 106 agreement for the fund, and that is specifically equally can be used for funding for health and wellbeing funding, but it could also be used for broader community funding as well. But specifically about that, it has a tighter boundary and a tighter spatial geography, so that's not district wide, but that's relating particularly to a number of key wards in and around where the West Midlands Interchange is. And then the last one on that list is the Communities the Best Medicine funding, and there's £50,000 there. Now that's already starting to be used, and a number of groups have already benefited from that. Communities the Best Medicine funding. There's been some funding for warm hubs across the district, and there's been some funding in terms of provision of I think there was a dishwasher to be able to support and help a group where they were providing a warm spaces, and various other different pieces of equipment that have been required. So the small funding packages available there across the board. Next slide, please, Mark. So in terms of that broader governance, there's obviously the big pot of money that Mark's talked about, and obviously we will be looking to hopefully secure that here early in the new year, that we will have been successful hopefully on that funding. But we've put together this governance structure, and it really replicates the UK Share Prosperity funding structures. So effectively, it will come to the challenge board, the corporate leadership team challenge board, which will look at the bids that come in, that will consider them against the criteria. It will then go to the partnership group for identification and for information purposes. And obviously then it will come to this group, to the Health and Wellbeing Select Committee, to be able to look in terms of what those funding opportunities are. And then lastly, obviously, the final sign-off would be the cabinet process. So alongside the criteria, we've got that governance structure in terms of ensuring that everybody who needs to be aware of the funding and the pots of funding and the bids that have been submitted can be. Next slide, please, Mark. So just in terms of that, so this proposed governance structure oversees the 4 health and community wellbeing funding strands. Obviously, we've got the lead cabinet member for this piece of work, which is the leader of the council. We have the health and community wellbeing lead officer, that's Mark, who's responsible for the leadership of the programme and reporting that to the corporate leadership team and obviously the wider membership. There'll be programme officers who deal with the day-to-day operational running of the programme, and obviously that will be reporting to assistant directors for community and partnerships, who will be able to make sure that those pieces of work are undertaken and the programme runs smoothly. The corporate leadership team challenge board, that group will meet regularly, but we will receive reports and recommendations from the papers relating to individual funding applications, understand the monitoring, evaluation and overall management of that programme, and we would meet monthly to ascertain that and to make sure that we were all up to date in terms of what's coming through. Next slide. We talked about the partnership, which is a group of people representing different organisations across the district. That's chaired by myself. But what we do is that we engage obviously other partners. We utilise we'll be utilising the existing partnership. We'll have a standing item on each agenda, as we do with the UK Shared Prosperity Office, UK Shared Prosperity offer, and we'd also provide updates on this programme as well. There would clearly also be conversations and opportunities for other partners as well to look into that and to bid into the programme. It's important though to note that at that level, that group isn't decision making, but it's advisory. And that we'll be having quarterly updates at that group. So we'll also be making sure that I think in answer to Councillor Harrison and Councillor Sutton's issues in relation to who knows about it, how do we know about it? Well, the more people we talk to about it as well, we would hope that they'll be spreading that message out across the board. Then also we'd be looking at cabinet members. Cabinet members will have a quarterly update on progress and commissioning decisions as to exactly where we were with each specific strand, and obviously any decisions that have been made. This group, clearly important within the remit of this group, the Health and Wellbeing Committee, we'll be having twice yearly reporting and an opportunity for members to be updated on progress, plus the chance to scrutinise any decisions made on that as well. So ultimately, that's what we have. We've gone through the broad proposal, we've gone through the rough criteria and the types of projects that could potentially be funded, and the criteria for the governance and the responsibilities within there. So obviously Mark's answered some questions already, but I'm more than happy to take any further questions. Councillor Barrow.
Thank you, Annette. All I would ask really is, can you make it as simple as possible for people to apply? Because this is always an issue when I'm suggesting to people that it's so complicated, people haven't got the time. It's very difficult. So all I would ask is paperwork to be simple, please.
Yeah, thanks, Councillor Barrow. We've very much got that in mind, and I know with the UK Shared Prosperity Funds, what we've done, so we haven't asked for people to sort of waste a lot of time in something that we know that a first conversation wouldn't have got anywhere really. So what we've done is a two-stage approach. So we've invited expressions of interest if we thought that they had the opportunity to be fundable. Then we've invited then detailed bids to come in. And 9 times out of 10 they do, and 9 times out of 10 then they are recommended for approval. So and that's because we've got that two-stage approach, so it hopefully reduces that wasted time for particularly for community groups to do that. But what we'd identified with this, so I showed the slide with the 4 strands, there'd be an umbrella so that you'd have there would be paper versions, so we would accept paper versions, but ultimately you'd be able to see which bit of funding, how do you fit into it, where's the best thing. And ultimately, if somebody phoned us up and said, we don't think this fits, actually, this is what I want to do, the beauty of the conversation with us then is that, well, actually, it might fit into a different category, or you might fall back into the UK Shared Prosperity funding, where it's a better opportunity. So always encouraging people to have a conversation with us. Unfortunately, though, there is going to have to be a degree of monitoring for obvious reasons, but no, simplicity is key.
Thank you. Are there any other questions or observations, please, ladies and gentlemen? Councillor Hopkins.
Of setting up something to give people financial assistance, guidance, signposting. I know over the years we've advised do some of that, but I think they're quite often overwhelmed by the volume of people in need for it. Is that something that's available everywhere else, including in this funding? business open, somebody could improve their own personal finances through the knowledge base, they might not be quite so reliant on food banks or other such systems. Is that possible?
The criteria for the comp funding is quite tight in terms of how we deliver against that, but potentially for some of the other funding pots, although maybe not the same scale or funding available, people have been quite creative with the community's best medicine funding and utilised that for a number of groups. Really, the focus was originally around warm spaces, but we know there's a number of groups that offer that by default, but that's not their primary purpose. I think it's trying to get people into those groups and to reduce isolation, get them involved in other community groups. So there may be a way around that, but by the inequalities funding, probably not, because it's quite tight criteria we need to feed back on regarding those original aims of the comp grant.
I think there may well be some funding opportunities though through the people element of the UK Shared Prosperity Fund. So if you remember Creating Brighter Futures programme, there may well be some funding opportunities there in terms of helping people to in terms of financial well-being as well.
Thank you, Anna. Councillor Sutton, please.
Yeah, to answer that question as well, I think certainly from the point of view of budgetary advice and guidance, we certainly in our area, because of the rurality of the area that I and Sue represent, Councillor Shalapsky represent, we've got a lot of assistance from the BBO, which is now called Brighter Futures, and also the CAB. They're out, although they don't come out outreach, they certainly do telephone advisory service. So it's well covered, especially with more rural areas that we represent in our particular locality.
Thank you, Councillor Sutton. I would actually add to that with Councillor Barrow that with the Cotswold Warm Hub, we do have BBO representatives coming in. We also have Citizens Advice Bureau, and we do help people, but obviously because we have to keep it confidential, we're very careful with how we handle that, and sometimes we do see people beyond the hub, don't we, Megan? But we do the same. Thanks for that. Yeah. Okay, does that help you, Fiona? Okay. Over to you, Mark.
Yeah, sorry. Again, we wouldn't rule it out. So if there is a bid or local groups thinking of it, if there is anyone in mind, if you can have a chat with us, and then we'll check with colleagues at Public Health whether that's an option. I wouldn't want to rule it out at this stage. If it is a good project, I wouldn't want us to miss a trick if we can try and have a positive conversation with colleagues at Public Health.
I have to just finally add to with regards to the warm hub, we have had a few people coming in who need help with budgeting, and that's something we've managed to do with them. So it does combine with particularly CAB and then BBO, but the BBO girls are very, very good. Okay, thank you. Okay, well, thanks for that, ladies and gentlemen. I'm now going to move on to item 5. It's the Health Watch update, sales tax from Baz Tanis, who is the Health Watch Strategy Manager. Baz, over to you.
Okay, thank you. Thank you very much. Yeah, I'll give you an update today on our work programme. Next slide, please. So to be going over our current ongoing work, how we work with our partners, how we communicate, how we raise awareness of communities through our outreach, we give an update on our 3 deep dives, and setting key priorities. So the way we help Watch work at the moment, we look at our day-to-day work, which is what I'm calling here the reactive work. So this is when members of the public can contact us, whether it's via the free phone, email, website, face-to-face events, etc. Whichever way, that could be anything to do with health and social care coming into us. And then we have our proactive work, which is our 3 deep dive areas. So this was set up when we took over the new contract, coming from patient-led, so bottom up, if you want to call it that, on the key priorities. This being access to primary care, face-to-face, being seldom heard. Root causes. I've got a poor teenage mental well-being and health outcomes when you've been in care as a child. So that's part of the proactive work. Also part of the proactive work was our encounter review, which is our statutory power where we can do a spot check. We don't necessarily need any feedback to do a spot check somewhere where there's a health issue. The idea really is that we can just do one, and that's to make sure that things are running the way they should do. But at other times we do get some feedback. We think, oh, there's something going on here. Maybe we do need to go in and just make sure things are working the way they should be going on. So organisations like MPF people have reached out to us, who said, can we do joint entry reviews with them on their quality internal visits on their various business centres. That's going really well. Similarly, we've done a entry review recently at Royalstone Maternity Ward. All of these entry reviews, what we do try to do is, one, working in partnership with those partners, we do try to give these reports back initially to those trusts to give them an opportunity to comment on before we go out to publish them. And you can find all these on our website. If you struggle to find it on our website for whatever reason, just please give me a call or drop me an email. I'm happy to send you the link directly so you can look at those and see anything that you might want to pick up in those areas. Similarly, we also have our Health Watch Intelligence Network. So being part of Support Staffordshire, here as the host organisation, they do have many members within the VCSE sector. So it gives us the opportunity to use their existing networks and reach out to those partners and get into those places where we may not hear those voices otherwise, to kind of support that from our side. And again, we do use a lot of Support Staffordshire partners as well as consultancy to help us to expand our reach and vice versa. A lot of the times what we do notice as a health watch is that patients and residents do often feel they don't get to directly necessarily talk to a lot of the services, and they often do feel that they're making those decisions. So we do get those feedback, and we do work with our patients. We do try to take these up to as many of the different organisations as far as the ICS itself and the ICB board. We've set across various different boards. We have the opportunity to bring up key concerns raised by members of the public, and then for them to give us opportunity to, give them the opportunity to tell us what they're going to do or what's going on. Because sometimes what we do find is, or more often, is that the health social care sector are putting things in place, but they're not able to always bring members of the public along on that journey. And we'll pick up a little bit more about that in a few slides further along. So what this is the process of is transferring that information back and forward from members of the public to those key places to influence that commissioning process, to influence future strategies and contracts, and that specifically is taken from the patient feedback that we're getting. And then we're able to also bring back down to patients and residents what is going to be happening, what's going on currently, to give them some reassurances. So how we raise awareness, we have our website. We try to keep that up to date. We have, like I mentioned, the Health Watch Intelligence Network. We do publish our reports. We have our social media, our e-bulletins. We have got a list that's growing now on e-bulletins, our distribution list. Again, these are on our website, but please reach out to us. We're happy to put you on the distribution list. Our e-bulletins, we'll pick up those key highlights on the key health and social care themes and trends that people are raising to us. We also have our annual report that comes out once a year. Every quarter, I do see the Health Watch Committee, our own Health Watch Advisory Committee, and that is an open public meeting, so anybody can join in that. Our link for that is always on our website. So you go on the homepage, you'll see it on there. You click on there, you can come into that as a public meeting. Again, if you have any issues, please give me a shout. We do work with other local health watches, such as Health Watch Stoke. Then there's also Derbyshire, Shropshire, and there's always a crossover, and Health Watch England itself. And then we do work with the VCSE sector. And then any public engagement or events or online or anything like that, just to get that message out. So this here is the ICS's vision. So what we do try to do is work as one system. So we are independent and we do try to maintain that independence. We do want to be a part of the system as much as possible. So as you can see in the middle there, you've got the 7 ICS portfolios. What we do try to do is when we do get that patient resident feedback, we do try to feed back into those as well to help influence how they're carrying out their and informing their work to have the maximum amount of impact. We are making these links more and more and networks so we can have that data transfer back and forth both ways, so we can enhance how people are receiving those services and hopefully improve the patient experience. So moving to our deep dives, the first one being root cause of good and poor teenage mental well-being. Now this, again, there are 3 deep dive reports coming out. They should be out by next Friday at the latest. It should be published on our website. They are very detailed. There are a lot more in there. This again is just picking up those key highlights from there. What this deep dive was looking at was firstly the root causes, looking at what some of those were. For example, family dysfunction or child neglect, abuse, trauma. There's severe long-term stress, loneliness, etc. Some of those symptoms, again, they're not so to this could be due to other things. It's anxiety, depression, PTSD, low self-esteem, isolation, and suicidal ideations. And then it's just highlighting what the service provision available is out there for young people. Again, as you can see on the accommodations support services, there's EET, the education employment training. There is the one single point of access that put on here. So it's either the free phone number on there or the email that people can contact. And that could be for anybody, it could be doctors, it could be parents, it could be anybody that can make that initial point of contact. Overarching theme really was that there still seems to be those vulnerable people that are slipping through the net. It usually does tend to be more highlighted, especially when they're transiting from the young people's camp service into the adult mental health services. Some of them got brought up actually in another meeting in this week around adult social care, around mental health. It's something that often young people feel, they're not really consulted at that point. They're about the 17, turning to 18 age, decisions are made on their behalf that maybe they don't need further support in the mental health side, but they did feel like they did. The problem is that once they come out of young people's services, which you can imagine have a lot more put around them to support them, adult services are quite different to that. And similarly, they have to restart the process, which is quite a difficult process. People don't like to retell the story again and again. It opens up a lot of wounds for them. So some of the recommendations are about young people maybe getting referred to other support services to help them have that little bit more of a bridge and better transitions. And again, they like the idea of seeing somebody face-to-face appointments as opposed to maybe a physical element like a GP. If they've got a cold, they tend to prefer the idea of a phone call or over the Teams, but not when it comes to mental health. When it comes to mental health, they very specifically said that much more so prefer a face-to-face. It's really important for face-to-face, but they do like the option of the digital side. I'll let Dave comment on the access to primary care.
Right. I've been looking at access to primary care right across Stoke and Staffordshire. There's 142 GP practices, but organised in 25 primary care networks, so it's quite a big task. And between them, they're seeing 6 million patients appointments a year. Believe it or not, in August this year, they saw 25% more patients in August than they did in 2019-20. So although the demand, and as you hear very often in the press, the problems of patients getting appointments for GP surgeries still exist, they are actually doing 25% more than they were doing 3 or 4 years ago. There are various things that are happening. I've come to this committee before and talked about a report that was issued a couple of years ago now called the fuller stocktake on primary care, which was led by a GP in Surrey on behalf of the Department of Health, which totally looked at what was happening in primary care, and if there wasn't going to be any changes, it was going to become fairly unsustainable within the fairly near future because of a combination of an aging population, the backlog of problems caused by COVID, and the extra waiting times that are now building up, which with the hospitals, which is meaning patients are becoming more and more dependent on their GPs. So in the last 9 months, the government have issued a primary care recovery plan, which focuses initially on trying to tackle the 8 o'clock rush on a Monday morning when
everybody tries to ring the GP surgery at the same time. Nobody gets through. So trying to develop ways of improving that. So the NHS have been given targets to meet and support to address some of these issues. And I'll just go through a few of them now because it kind of highlights the point. First of all, a lot of the GP surgeries didn't have up-to-date digital telephony systems, so people were getting stuck on the end of endless waiting time for phones to ring and somebody to answer it. That's been addressed to a large degree in Staffordshire now, and 96% of practices are on digital telephony systems, which means they're far more able to bring people back, transfer calls between people around the system, and it's beginning to make a little bit of difference. The issue with patients is it's all very well getting through on the phone, but when you get through on the phone, you want an appointment and you want somebody to sort you out. And one of the things that is happening now in practices is that there are a wider range of people being employed in GP surgeries now, ranging from physios, mental health nurses, paramedics, physician assistants and social prescribers, for example. 616 been employed across Staffordshire so far, with a target of 730 by April next year. So when you ring the surgery now, the receptionist will ask you what the nature of your problem is. You don't have to tell them, but generally speaking, it helps if you do, because they then try and steer you to the appropriate person in the practice to deal with your particular issue. An example that I often use is 4 ladies in Tamworth who were all carers, who I went to a meeting and they said, "We're sick of our practice. All you ever get is their words, not mine, the bloody receptionists are Rottweilers," is how they describe them, and we never get through to what we want. So I said, "Well, what's the problem?" And said, "A lot of it's about medication." So I happened to be in a room where there was Wi-Fi, so I went on the computer, pulled up their practice on the computer and had a look at who works in the practice, and lo and behold, there's a pharmacist working in the practice. So I said, "Ring the pharmacist, try ringing the pharmacist," and rather than have a row with the receptionist for an appointment with the doctor, asked for an appointment with a pharmacist. Went back to see them a couple of months later, got greeted with a big grin and a hug. So we talked to the pharmacist. He sorted out my husband's medication. He organised the blood test. He booked an appointment for me to see the GP, and all the problems that they were having had melted away. So there is a wide expectation by a lot of the public still that they have to see a GP, yes. But there are now a whole wide range of other people working in primary care that can help you. You might get seen by a paramedic, because quite a few paramedics are now working in GP services, and one of them, somebody told me the other day, they went to see one and asked him, "Well, why have you come off the ambulances and working in primary care?" Well, first of all, I don't have to get up at 5 o'clock in the morning and do a 12-hour shift. And secondly, I see my family a bit more often. And 3, I can use my skills to assess patients. I can do home visits for doctors and report back. And I'm getting a lot more satisfaction out of my work. So that's the breadth of expansion of staff working in primary care. Also, the NHS app, which you may have heard of, the functionality of that's been improved so that now within Staffordshire, 90% of the public apparently have got access through their NHS app to make appointments for online with their doctor's surgeries, to look at their health records, to order repeat prescriptions and so on. Again, hopefully meaning that patients can start to, well, the ones who are digitally savvy, shall we say, can message into the surgery whatever time they want to, really, and their issues will be dealt with without clogging up the phones. There are also steps being put in place to encourage more inquiries to the practice online. You'll see on a lot of GP practices websites now forms to fill in to submit non-urgent requests and information to the practice. So trying to adjust the way they deal with patient inquiries, but also on top of that, there are plans in place to make some services accessible without needing to go through a GP in the first place. So you might have heard on the news the other day, pharmacies are now gradually being able to prescribe contraception, for example. There are plans to increase the range of things they can do. It's under negotiation with pharmacists at the moment because money comes into it somewhere along the line. That there's going to be about another 7 areas where pharmacists can, in the future, prescribe antibiotics for minor conditions and various things like that. And within Staffordshire at the moment, apparently 28,700 patients were referred from primary care direct to pharmacies last year, which is the highest number in the West Midlands. So again, it's another source of advice. Of course, that's leading to pressures in pharmacies because they're a shortage breed as well now. And in Derby, for example, half the pharmacists left the hospital to go and work in primary care practices. Well, now they haven't got enough pharmacists to deal with the extra outpatient clinics that have been set on to hit the backlog of following COVID. So people have been queuing up down the corridor waiting for their pharmacy prescriptions to be sorted. I think generally that gives you a bit of an overview. Face-to-face appointments within practices vary between 29% and 100%, with an average of 68% across the county. The practices have also been tasked with sorting out urgent appointments either on the day, well, they've got to give you some advice on the day of what to do, whether it's to be seen, a telephone call, or advise you where else to go to get your service. They can't just say no appointment, ring back tomorrow, like they have been doing for a number of years, when the receptionists just seem to be increasingly just like gatekeepers. So that's going on. Over 90% now of appointments within Staffordshire are being made within 2 weeks. That gives you a bit of an overview. Some of the areas that are being looked at to open up for direct access, so under certain conditions you wouldn't have to go to the GP for a referral. Low-level hearing issues, that's already come on stream, although it seems a bit convoluted when I've looked at the processes. Wheelchairs and community equipment, weight management, physiotherapy and podiatry, and talking therapies are some of the other ones that are either in the process of being looked at or already happening. So basically the message is the GPs are being tasked to change the way that they're working. The messages that we've been giving back to, and we've picked up from patients, and we've been giving back to the Integrated Care Board, who are coordinating all this work, is that none of this is going to work. None of this is going to work unless you take the patients with you. And in Newcastle, for example, the practice have texted out all their patients, and they're now running digital awareness sessions for patients on how to use the NHS app and how things are changing in the surgery. Some of the patient groups in other parts of the county are doing other things like that, and that's going to increase, I think, as time goes on. So hopefully going forward, there should be a blend of patients who can contact the surgery remotely by digital means, taking the pressure off the phone system, so that patients who want to speak to the practice and need to and don't like using digital services anyway, and there are a lot of patients that don't like using things, don't know how to use a smartphone, etc. The idea is that there'll be a blended approach which should take some of the pressure off primary care, along with a wider range of staff working in the practices, and, as I say, diverting some of the issues that go into primary care into direct access referrals. And then the final thing that they're starting to look at now is trying to, they call bureaucracy bust some of the interfaces between primary care and the hospitals, because I think the primary care feel that they get dumped on by the hospitals, and the hospitals feel they get dumped on by the GPs, etc. And to take out some of the sort of laborious extra work that creates, to make life a bit easier for all, so that more patients can be seen. I think that's it in a nutshell where we're at with it, really. The ICB have taken on board our feedback. They're particularly interested in the one thing that we flagged was around the way people with co-occurring needs, which is one of the other deep dives. People with autism and ADHD, how they're handled particularly by receptionists. Quite often they're the people that get struck off practices and the ones who have rows with receptionists, and then find themselves being told, go and find yourself another doctor. And the ICB are particularly keen to have a look at that, which was one of the things, around health inequalities that came out.
Yeah. So this particular deep dive here about access to primary care is the one that Dave has been leading on and focusing on. So it just felt, given the fact that this is the one area we mostly do get contacted about anyway on a regular basis, it has been the main thing. I do think it'll still be for a while to come, even for the next couple of years. So maybe, hopefully, things will simmer down. Yeah, I'm gonna just to go back one slide to the R's roles, just so I can highlight quickly on there. That's okay, thanks. So on here, we were quite fortunate because we were building up good relationships with the ICS. So some of the patient feedback that we were getting as a health bot and that were working with us and other partners was directly fed into the creating these adverts here. So you can see those little pictures on the side there. I did see one of these on the back of a bus in Newcastle. I couldn't take a picture. I told Councillor Jeremy Pert because I was driving, just to show, because he said he hadn't seen them, just to show that they are out there. So that's the ICB's attempt to advertise as much as possible to show that there's other ways of accessing primary care. And the idea of these R's roles is to alleviate that pressure and make things better. Now, each of these points here have a video attached to them. You've got the slides, so if anybody wants the slides, you can just click on there and you can go to the videos on YouTube, and there is an explanation. The last one on there is about the overview from Dr. Paddy Haddington about the idea of these. That's on there, and then it leads on to the rest anyway. So if you are more interested in looking at that a bit more deeper, then please do that. So we'll just move a couple of
access through my report as well when it comes out next week.
Yeah, it'll be on our website as well. Yeah. And okay, so the third project was our deep dive on seldom heard group. So this kind of branched out in 3 areas, almost become 3 mini deep dives, which was a bit of a challenge, I think, for Emma, our other engagement officer. First one being around work for the LGBT community, which should not go further down to the trans community within that, and what key, and then the second project was those people with neurodiverse conditions, as Dave pointed out earlier on, and then the third one's about rurality and those that struggle with living in rural areas. So yeah, so with this one here, what we realised was, as we were talking to the LGBT community, especially through Pride events, that actually they all needed and deserved their own focus. So whether it's the lesbian, the gay, the trans, they actually got their own concerns that they want to raise and how things affect them in their own particular way. And given how much time we had to focus, it was better for us to focus on an area that was really difficult, was the trans community. One of the things that they said that most of the times GPs didn't understand how to actually support them. They didn't know what to do when they presented with this idea that they felt they were in the wrong body and wanted to transist. There wasn't really any advice or guidance available for them. They had lots of mental health issues, especially when they were told it would take a certain amount of time for certain treatment, but it took a lot longer. We talk about years longer. So this became its own standalone as well at the beginning, and there was a report about this on our website. So if you want to go on the website again, you can see that report on there. And it's also to support anybody from any of the professions that want to read that just so they can support the trans community a lot better. We were fortunate enough to push this out to other local health watches and Health Watch England as well. So the second part of that is a neurodiverse. So here we was talking to, mostly it came down to talking to the carers, but and a lot of the carers talked about ASD, as mentioned before, autistic spectrum disorder. A lot of people said that they really struggle when it comes to seeing their doctors or when they want to see the GP practice. If we just move on to the next slide. Actually, no, sorry. Yeah, sorry, I'll go back to this one for yeah. So with the neurodiversity, the things that people struggled with was, as Dave pointed out, was that because they get easily frustrated and they need a lot more time and patience to express themselves, especially on the phone. At times, the receptionist would turn around and interpret that as a zero, thinking, oh, this person being very aggressive towards me, not recognizing they're just unable to really express themselves, and then apply the zero tolerance policy, which means, okay, we're not going to deal with you anymore. You're too much. You can't handle you. Not recognizing that this person has other issues going on that they need a lot more support around. And that did mean, as Dave said earlier on, that these set people were actually excluded then and asked to go elsewhere, which made their ailments even more difficult and impacted them a lot more. So we have been working with our partners in the ICS and various trusts as well. We did have all our raw data, which really went into a lot of depth about the actual feedback about how people from the neurodiverse community felt, what they were put through, the comments that were sent to them. People felt, sometimes they were laughed at, sometimes they were told off, sometimes they were, not, really felt embarrassed actually, belittled. And that raw data was passed back on to providers and to GPs where we could, just to show that. And the impact of that has been really, really well received. It's also been passed back to public health and it's been passed back to other partners just to do that. But again, this will be in the report itself, highlighting these key issues. Then look at the rurality one. So the third part was the rurality. Again, a lot of the people that we spoke to here said they did struggle, especially those living in rural areas. It affected mostly the elderly, those that didn't have access to transport. It was a lot of concerns around how much time and money it would take for them to actually make appointments. They couldn't afford, sometimes it was into cost of living, their prescriptions and making that journey. Some of the recommendations, and these are, again, few key ones here, there'll be more in the actual final report, was around using some of those more places closer to people in the rural areas, maybe some of those health centres to offer some additional services, and to look at wider partners and how we can support the idea of improving some of those public transport so people can find it easier to access services further away from their homes. And on to the next slide. So for our next year's priorities, there's a couple of options. We try to do this where we are looking at all the patients that have been contacting us. So try to make it from a bottom-up perspective. And the two main things, initially actually it was maternity that kept coming up. That was because of the CQC had been going around doing maternity visits and downgrading some of those maternity visits across, not just across Staffordshire, but across the country in a way. So it's universal in that sense. And highlighting things. And when we're talking about this with partners, we were looking at this was something that was coming up. We realised that we want to be careful of not duplicating already what's going on out there. There's a lot of people at the moment involved in maternity. How are we going to benefit that? So it doesn't mean we won't be doing stuff like we said. We did do the end review on the 20th of November at Royal Stoke, maternity and neonatal, but it doesn't mean necessarily we might do a deep dive on that. But that was an option on there. The other option one on there, was around the patient journey effectively. So this is from that moment of the 999 call, something that was discussed earlier on as well, on the first item about prevention, maybe falls, looking at that. So looking at that 999 call, what's happening? Why is it taking so long for ambulances to get to places? Why are ambulances waiting outside hospitals for several hours so they can't be released for the next job? So that's the first part. The second part would be the actual treatment, the process in the hospital. Where's the VCSE sector? Are they involved earlier? What else is going on there? And then it's the discharge process. And then that's looking at maybe are medicines dispensed in time? Is that delaying it? The D2A process, adult social care, etc. So it's quite a variety. So that would be the patient journey. That's kind of the timeline on it. It looks more so that would be the one we may be leaning towards doing. And again, I can't emphasize enough, it is we're trying to make sure it's based on what we're hearing from patients to be as and to be as effective as possible.
I just have one. Yeah. So you know the chart you put up where we show the different levels of the organisations and how the arrows went from the top to the bottom. I had an example of that one day in Burnley. The chair of the patient participation group rang up saying, "We've been hearing stories about our practice is going to be dissolved. What the hell's going on?" We got an answer from the ICB in 10 minutes about what was happening. We got agreement that if we got permission from the chair of the group to give his communication contact details to the ICB, they would get in touch with him. And on the back of that, 2 directors from the ICB went out and met with the patient participation group and dealt with their issues. So 1 email, 10-minute response, we sorted it. So that's going from the bottom to the top in 10 minutes. So the links that we've got within the organisations and the contacts that we've now made can be very effective in getting things done quickly when necessary. I think that just illustrates the point.
Brilliant. Yeah, that's it. We'll just end the presentation. Take any questions. Thank you.
Very helpful, gentlemen. I'll take questions now. Councillor Nelson first, and then Councillor Harrison afterwards. Thank you.
I was just wondering if the investigations that you do, the deep dives and things like that, is there anywhere like private practices or things like that that won't give you information?
Yeah, primarily as a health watch, we're set up for those from the public purse. So if it's health and social care in the public purse, yes, there will be some regulations around those private institutions, but I think that we might be more covered by the CQC side than it would be as a health watch. We're primarily our primary basis is by statute is those that are through the public purse.
Where we do come up constantly against the private sector is over dentistry, because as I'm sure you'll know, trying to get an NHS dentist these days is virtually impossible. We've certainly collected a lot of evidence that we submitted. There was a parliamentary inquiry looking at the issue, and we submitted evidence to that. And I actually go to a Shropshire and Staffordshire local dental committee meeting every quarter, where hospital dentists, public dentists and private dentists will meet together to thrash out some of the issues, because there are still issues about private dentists referring patients to dental hospitals for procedures, etc. It's quite interesting sometimes to hear from the hospital consultants about the standard lack of it, some of the referrals that they get. Yeah, I mean, the dental world's changed very much.
Yes, to bring it back on that dental one, Health Watch England did reach out to us and other local health watches and asked us to carry out some surveys across Staffordshire. I think we got about 70 surveys back, and some testimonies. Yeah, it may have creeped up more than that. And that was passed back on to Health Watch England. About 30 other health watches nationally fed that back, and there's a report. I think they had over 3,000 responses and all that, and that was taken back to Parliament. So that's the NHS dentistry in Parliament. So it does have an effect in that way. Yeah,
we were approached a couple of weeks ago. The consultant in dental public health was doing an audit of the hotspots in Staffordshire, and they collected their data through other sources, but they asked us to feed back to them what we've been collecting and where we thought the pressure points were within the county. So we produced something fairly quickly and sent it back to them, and they found that quite helpful. And we also included some of the comments that we were getting from patients, like, for example, a lady who was on maternity leave said, "I'm supposed to get free dental service while I'm on maternity leave. I can't find a dentist to do it." Yeah, for example. Lots of other things as well.
Good, thank you. Councillor Harrison, please.
Thank you very much. Thanks for the presentations. I thought they were useful, and certainly you've done some very comprehensive work there in terms of the deep dives. And as an aside, I was impressed with the number of three-letter acronyms you managed to get in there, or TLAs as I prefer to call them. Particularly via R's, which is a new one on me. That was quite impressive. But on a serious note, in terms of the work that you flashed up at the end that you were considering doing next time round, deep dive next time, the what happens with emergency admissions all the way through to discharge is clearly a major issue, and it's something that you'll be well aware of, and I suspect everyone in the room is, that all aspects of that are something that people have been literally pulling their hair out trying to sort out for several years now, and it's 2 steps forward, 1 step back as far as I can see, for a variety of reasons. It was just really that's a huge task in its own right. You talked about some of the work deep dive you did this year, fragmented into different streams. I mean, that if you take the whole of that chunk, that's a huge undertaking. And I just an observer from someone who's been involved in this sort of thing, you know, maybe it would be better to concentrate on an aspect of that, you know, admission avoidance, or what actually holds up the discharges, because I think probably you get better bang for your buck in solving one problem rather than necessarily having the resources to solve what is essentially the problem of the NHS, which is what the rest of that is about.
Yeah, no, I welcome that. You're not the first one to say. I mean, the way you've said it is definitely a better way of articulating how you said it. You're not the first one to say that, because I have spoken to other colleagues, like I said, in public health, both colleagues in Statutory Council. I've spoken to colleagues with the scrutiny committee and a few others, and they do say very similar things. So again, this is why at the moment it was very much options. The detail itself, we've got to knuckle down and make it, because you can go into non-urgent person transport, it can branch off before you know it to many areas. So and even when we discussed it as a team, initially the team's reaction was, that's a lot of work, you know, and it is. So we're gonna, we'll take that on board. So thank you for that. We are going to be trying to be careful to narrow it down to very specific bite size so we can achieve something.
I was talking to a patient yesterday who went to the Derby Hospital in an ambulance on Thursday and arrived to find 21 ambulances outside A&E. She got there at 12 o'clock. She left at 1 o'clock in the morning. There was nowhere for patients to go. There were 5 of them sitting in the relatives' area waiting to be seen because there wasn't anywhere else to go. There was an elderly lady who needed assistance to go to the toilet. One of the other patients had to take her to the toilet because there weren't any nurses to do it. And that was last Thursday. And then in the middle of all of that, the IT system in the hospital crashed, so they couldn't get any X-ray results. They couldn't get any blood tests for about an hour, just to add to the fun. So that's just A&E.
Sorry.
Oh, that's
Absolutely. I wasn't in any way suggesting that wasn't a huge problem, and there was a huge amount of work to do. It's just that I wish you good luck with it. It's one thing.
right. Thanks, Art. Okay. Thank you, gentlemen. Thank you for the presentation. Councillor Ashley, please.
I think the information you've given us is interesting, but I have great difficulty relating your information to what we can do with regards to residents. But you did raise one issue, because we know the NHS at the moment is in dire straits. But it's the question of patient participation groups.
Yeah.
You mentioned that.
Yeah.
Now, I was a member for some years of my local GP group. And quite honestly, I found it to be a personal complaints group section.
Yeah.
Because all that the normal patients tended to do was discuss their own ailments and problems.
Some of them are like,
And I often thought, well, how does that go to reflect back to the GP groups, the people in the GP area, as to what we can do to improve things? I mean, at the moment, I think to actually see a doctor is an achievement, because it seems to me now that pharmacists are becoming the first line of consultation people who have ailments. But what is your opinion on the effectiveness of patient participation groups? Because we represent, if you like, our residents in whatever area we are. Now, the point I'm trying to make, are they worth, are they of any use?
in some parts of the county, they are more effective than others. For example, there's a practice in Kidsgrove in North Staffordshire where the patient participation group has produced a series. I've got the chairman who's IT savvy, but he has produced a series of podcasts from different members of the team. So one of the GPs has been online and explained how they deal with appointments in their surgery. Different members of the team are the ones, and then what they also do is, because they know that everybody doesn't use the internet, doesn't use podcasts, whatever, they also print off some of them, put them in the local shops. They've also joined in with the doctors in organising some training for patients about digital access, and they're also working with a number of practices. There's another practice, a couple of practices that in East Staffordshire that I work with, that have organised health and wellbeing events in the village hall. They've got like 20 or 30 health organisations together with stands on Saturday morning. We invite the public in, and they've had dozens and dozens of people coming to those events. And more of the primary care networks, as they get better organised now, and with some of the advances they've got in their digital capacity, one of the things that they're looking at now is what they call population health management. Whereas you look at the general trends of healthcare in your area and what you can do as a group working with patients to promote health and well-being. So we're seeing more some of these health and wellbeing events being set up where people from the primary care side and from the patient are working together. In East Staffordshire for years now, before they were disbanded because of CCGs, they disappearing. The CCG had a patient forum, patient panel, which directly addressed issues with members of who were making the decisions about what goes on in their area and priorities. And for example, the diabetes group in Burton orchestrated a meeting eventually with 250 health and social care staff, doc GPs, ICB staff. The finance director from the ICB was there, particularly looking at the lack of diabetes services in their area. And in Staffordshire, when COVID happened, the BPGs in the area were approached by the primary care network and said, can you get some volunteers to help with the COVID vaccination? 100 volunteers were found in 2 weeks, and over 2.5 years, they supported the vaccination of 250,000 people. So there are groups out there that are working. It doesn't always work. It depends also on who you can persuade to join the groups. I used to chair one in my practice years ago now, and shall we say that the age range of the participants probably mostly started at about 50. One or two of them have got some younger people in, but I think trying to get younger people in is sometimes difficult. But more and more, the hospitals are doing more engagement with the public. I was on a meeting with the Derby Burton hospitals today and Elsewhatch, Derby and Derbyshire. There's a lot of work going on directly talking to patients on how they're going down to maternity when mothers are having babies and children are going into the neonatal unit. The engagement staff are going down, being phoned by the wards and going down and talking to the patients. There are various ways you can do it. There's a deliberative event in Staffordshire tomorrow talking about the midwife-led maternity units at Stafford and Lichfield that are currently closed because there's not enough midwives to run them. There's all sorts of things going on, and there are opportunities for people to get involved around particular interests. There's a lot of work being done by Midlands Partnership Foundation just with mental health service users now, and they talk about co-producing services, etc. There's a lot more work going on. So there are different ways that patients can be involved. But I agree with you that where a patient participation group with a practice is effective, it can make a difference. But in some of them, it's just a moment shot. And like everything else across Staffordshire, there's so much variation.
Right, thanks very much. Thank you, gentlemen. That's very helpful. I'm now going to move on to item 6, which is the work plan 2023-24. It's a verbal update from the Assistant Director, Community Service, Mark Jenkinson. Thank you, Mark.
Thank you, Madam Chairman. Members, just to update on some of the agenda items members have asked to be brought forward as part of the committee meeting, so they will form part of next year's meetings. A number of those agenda items will hopefully be coming up with a positive update regarding the health inequalities funding that we've managed to draw that down and give members an idea of how that will look to be utilised across the patch, what groups and organisations have bid into it, and hopefully that will help us address some of the health inequalities challenges across the patch. Similarly, Chief Inspector Cotton or Inspector Platt will be back with Maggie Quinn and Mark to give an update on the community safety plan in terms of progress, where we are in terms of the outcomes we'd set. Similarly, we're waiting on some detail to come back regarding cross-border working, which Councillor Harrison, Councillor Chapman and Councillor Perry spoke to Councillor Pert about in terms of how can we look at that at a local level within South Staffordshire. And again, members raised at the last meeting regarding an update on breast screening, prostate cancer as well. So we'll be coming back with that. Again, members will be aware that we're looking to have one of the screening units based here in Cotsall. That predominantly covers the practices within locality 4, but there are other practices as well. There's a mobile unit in Warnbourne, and members patches in the north of the patch will need to go to other areas. So what we're trying to do is get a collective view of how that's gone across South Staff, not just what's happened within the Codsall area. And again, a pre-meeting yesterday with Councillor Chapman, one of the areas we looked at was voluntary sector support in terms of cancer support groups. Councillor Chapman mentioned a good group in locality 4, but again, I think it's that replicated across other parts of South Staff. Is there potentially more we can do in those areas? And as always, members, if you have anything you want us to look at via Councillor Chapman, please let us know, and we'll hopefully get the relevant body to the group, providing it aligns with the joint code of conduct and we're not duplicating anything county committee is looking at. Thank you, Councillor Chairman.
Thank you, Mark. Members, have you got any questions you want to raise or concerns? No? Okay. It's been a good meeting. Thanks very much. And I'm going to close the meeting now. I'm going to thank the presenters, all of them, for the work they put in. And thank you also for coming and seeing a very cold night. And it's good to see you all. Okay, thank you very much. Good night.